Welcome to Leveraging the Laboratory, a Mayo Clinic Laboratories podcast for administrators, outreach managers, and laboratory professionals to learn how to best leverage and optimize the laboratory for patients, clients, and staff. I'm your host, Jane Hermansen, outreach manager at Mayo Clinic Laboratories. Joining me today is Camille Jewell, a member of our phlebotomy team within the Department of Laboratory Medicine and Pathology at Mayo Clinic. One thing lab outreach programs sometimes struggle with is developing a home phlebotomy program. Drawing blood may not be any more difficult, but the structure and processes are certainly not standard to most organizations. So Camille, I'm hoping that you can actually help enlighten me today and our audience. So let's start. Tell me a little about yourself and your role at Mayo Clinic.
Hi. So my name is Camille Jewell. I have worked at phlebotomy at Mayo Clinic for almost 26 years. I have worked in both inpatient and outpatient settings, and I've been doing outcalls for about right around 20 years.
And when you say outcall, that is what we call home
That is what
phlebotomy
we,
in our Mayo
yes.
Clinic language.
Yep.
Okay. So from your perspective, why do you think a lab should perform outcall or home phlebotomy?
I think the main key driver is that it helps prevent hospital readmissions. And it's also a great community service to our patients.
And when we provide home phlebotomy, if you have some basic qualifying patient needs, it can't just be somebody who's too lazy to leave the house. I'm getting my nails done in a
Yep.
few minutes. I don't have time to get my blood drawn. Tell me more about that.
So we kind of go off of the Medicare's definition of a homebound patient, where they need the help of another person or medical equipment to leave their home, or the doctor believes that the patient's health or illness could get worse if they leave home, and if it's difficult for the patient to leave home and they typically cannot do so.
Okay. So these are true medical necessity items.
Yes. Hmm.
Do you have a position or any thoughts about performing home draws out of convenience?
So we do occasionally do that, and some of the reasons for that is beyond the medical necessity are that we provide our service to caregivers that cannot leave family members due to their medical conditions. Or sometimes it's the expense or the anxiety for patients, the expenses like the taxi or the zips. Some of the zips cost, $75, $80 each way for a patient to get in just for a lab draw. So there's a few examples of why we would go to a patient's home.
Sure. And Zips is our kind of local, like a medical transport
Correct.
taxi service, right?
Yep. Yep.
Certainly not affordable. So in some markets, what I've learned is that the patient who needs their blood drawn, maybe they don't drive and they have to
Yep.
have their child drive them in instead. So
Correct.
the offspring might be willing to pay $50 in order to have somebody come to the house and draw blood so that the
Yeah,
offspring doesn't have to take half a day off and come and do that.
exactly. Because otherwise they're using a lot of their vacation days to take
And
off
how
and
how do you
transport
manage
patients.
those? So how do you manage those, Camille, when you think about that? Now you've got your homebound patients, right? You've got your
Mhm.
medical definition. How do you handle those? Is it something that somebody just calls you up and says, "Hey, I can't, I'm the caregiver, I can't leave, I need that
And that
blood
is
drawn."
actually completely determined by the physician.
Oh,
And as long as their physician deems them that that's the best for them, then we go out and get the patients.
got it. Okay, so it's all determined by the physician. You don't have a little, "Hey, call this number if you want us to come and draw your blood."
Yeah, I mean, when we have patients that stop in at the clinic, if we do find that they're having a lot of difficulty getting in and out of the vehicles, getting into the lab, a lot of us do mention to them that, hey, we do provide this service because unfortunately, a lot of people don't know about our homebound care for patients.
Sure.
And so then we just tell them, to reach out to their physician and see if they can get it scheduled as an outcall.
Got it. Okay. So obviously, when you use the magic word scheduled as an outcall, how do
Yeah,
you manage the patient scheduling? I mean, you're one person and you can't be
yeah.
everywhere. Tell me more.
So all of our patients are put onto a DAR in Epic, and all of our patients are scheduled there through their providers. Now, we do have some days that we have like usual days for some nursing homes. So if it's a lab that just needs to be done around that time, then they can be scheduled on the day that we're going to already go to that facility. But of course, we'll go to that facility whenever the doctor deems it's necessary for the patient to have their lab drawn.
Sure. So that's for the nursing homes. And now you use the term DAR in Epic. Is that
Mhm.
a specific function in our Epic computer system? Do you know what that?
Yeah, that's the department appointment scheduling. So
Oh, got
each,
it.
yep. So that will and we pull that up every morning, and whoever's on it, we enter in our labs, and then we'll go draw those
Okay,
patients.
okay. So how do you confirm that appointment? Let's say you've got three patients that you're planning to draw in the morning. How do you confirm? Do you do it the day before, the day of? Do you call? Do you text?
So we do not call our patients in advance. That is up to the provider's care team to notify the patients. And we
Oh,
do not
got it.
have time set because our patients are deemed homebound patients. So we just assume that those patients then are going to be home because they're homebound patients. So we
Okay,
don't have an actual schedule, because sometimes throughout the day our schedule is, we'll have one that we have to go get across town, so we just never know what time we're going to be at each place.
okay, interesting. So I've seen other groups will actually call, they'll actually schedule ahead of time. So they have their itinerary, they'll have plan their driving routes, and then they will call in advance, call the day before, and they won't even show up at the place if they haven't gotten a response from the patient.
Okay. And we still do go to the patients,
Okay.
even,
And
yeah.
have you ever had a no-show? So you go knock on the door and
Mhm.
nobody's
Um,
there.
we do get patients that are not there, and then we call the care team, the provider's care team. We have them reschedule the appointment once they're able to talk to the patient and see when they'll be available. Um, Now, we do have some patients that, we see on a very regular basis. And so if we show up at their home and they're not there, we do get concerned. And so we'll reach out again to the provider and make sure that somebody can track that patient down to make sure that they're not laying hurt in their house or something.
Right, right. Yeah, that's well, and that's great that you have established those relationships over
Yeah.
time. And I remember back to my old days, I used to work in a hospital lab and I used to draw blood from people. And we had one homebound patient, and we
Yeah.
really did get to know the family. And
Yeah.
it was really it was important for us to be able to make that connection and
Oh,
provide that
very,
service.
very much so. That's very important to us.
So, so the no-shows, obviously that happens.
Hmm.
How about just preparing the staff? So you do this, you do it, I'm assuming very well. You've been doing it for 20 years.
Hmm.
How do you prepare a phlebotomist to do a home draw? Is there etiquette, additional training, safety concerns? Tell me more about how you actually equip someone to go into a very different environment to perform this service.
So what we do is we train them by doing what we call a ride along, where they shadow one of us three technicians. And like I said, each of us technicians have been doing this and had many, many years of experience. The ride along is mainly to teach them where the facilities are, the different buildings at some of the facilities, what entrances to use, the door codes to get into places, and where to find patients if they're not in their room at a facility.
Mhm. And how about within a house? So you're going to go knock on a front door. Yeah, or is
Hmm.
there a different set of protocol that you'd be using for those true homebound patients that are
So
in
we
their
do give
homes?
our patients a pretty good long amount of time to be able to make it to the door because they're elderly patients and they have a very difficult time. Um, some of our patients that we go to, all the time, we know that they just leave the door open for us. And so for those patients that we have a relationship with, we will just enter, calling their name,
Hmm.
letting them know that we're there because it's too difficult for them to get up.
Right.
But in a home that we have not been to, we would not just, of course, enter it.
Right, right. So then you
Yeah.
knock and you'd wait. And is
Yep.
there just so during their ride along now, they're observing you, they're
hmm
learning from you. Do you have a policy specific to these outcall types of situations?
Not really, no.
Mhm.
I mean, we
Okay.
have an outcall SOP, but it
Hmm.
doesn't go into detail on stuff like that.
Right. Okay.
And if the patient's not home, we do also um, get their phone number and try to reach out by phone too to see if we can track them down that way.
Sure, sure. Okay. Now, when you actually come into these scenarios, obviously off of the Mayo Clinic campus, you don't have access to our normal stuff. What kind of
Mhm.
equipment do you provide? Is there anything beyond standard? So I think about transport materials, bags, coolers. I've
Yeah.
even seen centrifuges that you can plug into the cigarette lighter on a car. Tell me more about the stuff that you need. Is there anything different beyond your standard?
So we do have centrifuges in our car so that we're able to spin samples down. And then we each have a PDA and a printer for bedside ID of patients. And then we each purchase our own bag to carry the supplies and we stock it to best fit us. Um, and then we have phones, and we're currently in the process of getting smartphones. We also have 3 fleet vehicles that we use on a daily basis. And then we have mileage sheets and travel allowance logs so we can log the facilities and private homes that we have gone to and the mileage so that we can correctly charge the
Hmm.
patients.
Hmm. Sure, absolutely. Well, you hit all of the right stuff there, and I like that you're able to customize based on the supplies that you think you need,
Yeah.
because you
hmm
know these patients, right? You've drawn their blood
Yeah.
before, you know what you need. So, do you have any other policies? I'm thinking about ways to manage your own personal safety,
Yeah.
dealing with pets, other family members that might be there, that kind of stuff. How do you
Yeah.
handle putting a person alone, sending them out there into kind of an unknown environment?
Yeah. So we always try to be very aware of our surroundings when entering a patient's home or a different facility. It is our policy that if a patient has a pet, that the pet is secured in a different room. We're also mandated reporters. And if we do notice a difference in the patient's hygiene, mental state, or cleanliness of the home, we do again reach out to the provider to make them aware. Um, and there have been times that we have also had to call 911 due to a patient falling, having shortness of breath, low blood sugars, and things like that. So then we would stay with that patient until 911 reaches them.
Sure, sure. And I just know some patients, it's really hard just even to straighten their arm out. So are there
Oh,
some that you say, you know what, this one is one I need assistance. So you bring a colleague along with you, or do you have someone available to help hold?
yes, we do have some patients who have some mental challenges, and so we do have to have, another technician there to help hold their arm. And there have been instances that we don't feel safe in a certain facility, so we'll send 2 of us together. Things like we try to kind of work together as a team when we're out there. So if somebody needs assistance or help with something like that, we call each other a lot and help each other out.
Sure. That's fantastic. So really what you have are three people who deploy every day and they go out to different
Yeah.
places, and then they're always in our community. There's a lot of driving that you can do in our town to hit all the locations. And
Oh,
then they just bring
yes.
everything back in and huddle up and go back out again.
Yep. And we actually go outside of the Rochester area too. So I mean, some days we'll put on over 100 miles.
Wow, wow. So
Mhm.
how far out? 20 miles, 30 miles?
So we do private homes, about 15 miles around Rochester. But we do go further to other nursing care centers
Got it.
because we follow our nurse practitioners. And so we'll go anywhere that our nurse practitioners go.
Got it. Okay. All right. So what I like the most about how we are handling this, Camille,
Mhm.
is that it's all tied to the patient care episode, and it is
Mhm.
viewed as really it's practitioner driven, it's patient care
Yes.
driven. It is not a retail service. It's not a commercial
No.
service. It's something that is truly aligned with meeting the
It
needs of the
it
patient.
really is. And we get a lot of great feedback from our patients at how much they truly appreciate this and how what a big lifesaver we are that we're able to go out and provide this service for them.
Well, that's fantastic. Well, and that's why we're here, right? So
Hmm.
you've been doing this for a long time. Do you have any
Hmm.
interesting anecdotes, any stories that you want to share?
Yeah. So, so our outcall practice actually started around 1978 with
Wow.
approximately 11 patients a week. And now we see like 50 to 60 a day. And one interesting thing with that is one of our patients who was one of the first phlebotomists to go out into the field is now actually one of our patients.
Oh, oh,
So
wow.
it's just that full circle of being able to
Yeah.
now be able to provide that care for our one of our phlebotomists that
Yeah.
helped start and grow this to begin
You
with.
bet. Well, and it just
So that's very special to us.
you bet. Oh, that just warms your heart. And
And it
I'm sure,
does.
well, and for her to see what she helped build,
Yes,
right?
yes. And
And
she is truly amazed at how much it's grown and the technology that we now have that, are able to make it easier for us,
yep.
you
Well,
know?
and safety. Yeah. If you think of
Yes. Yeah.
1978 blood draws, it was a whole different world back then.
Yes,
So,
it was.
wow.
And
Oh,
then we
that
have,
is great.
a lot of just unusual circumstances from our years of travel around. There's times that I've had to climb up a ladder to get into a patient's house.
Wow.
We've had to shovel out because we've been stuck in blizzards, rainstorms, car issues, things like that. I'd say, but by far the best thing is getting to personally know our patients and sharing in the difficulties of life with them. At times, we're the only people that our patients see, and they truly look forward to our visit, even though we're only there to draw their labs.
Yeah. Well, and you are the face and the hands of the laboratory. And truly, as a phlebotomist, that's from a patient's perspective, that's how their lab experience is always defined.
Yeah,
And you've just been willing to get in the car and drive through the snowbanks, climb ladders, and actually do that service. So, Camille,
yeah.
I thank you. If you were going to give a tip to anybody who's saying, should I do outcall phlebotomy? Should I not do it? Any tips that you would give them to say, here's why it's important, or here's how you feel it's been able to be a strong activity for our own organization?
Just that, we really care about our patients, and it's truly rewarding to make such a difference in our patients' lives. I mean, they are so appreciative and kind and overwhelmed with joy that we can provide this service and help them in their life.
Yeah. Well, that's fantastic. Well, and you do. So thank you so much, Camille. I have learned
Yeah.
a ton today about what you do and a service that I wasn't terribly familiar with. at Mayo. And I think our audience has probably learned an awful lot too. Thanks
Oh,
so much.
good. And thank you so much.
Got it. So thank you to our audience for listening to our podcast today. And I want to remind you that registration is now open for our 35th Outreach Conference, which is held in Rochester, Minnesota, called Leveraging the Laboratory, sees tomorrow, September 17th and 18th, 2024. And for more information on that conference, please visit our mayocliniclabs.com website, click on Education and Conferences, and I really hope to see you there. Camille will make an appearance and you'll get to meet her as well. And thank you all for listening to Leveraging the Laboratory, which is, of course, a podcast from Mayo Clinic Laboratories. If you've enjoyed this podcast, please subscribe. And until next time, we encourage you to continue to promote the needs of your community-based laboratory. The needs of the patient come first.